no real good symptoms, physical examination was good, the blood pressure was pretty high when you measured it in your office. It was over 180 to 100, which is quite high for this young guy. The ECG was normal. These are the home readings of the person. You heard that he was in the fitness gym and he was on holiday. These are his readings here from his holiday Florida vacation. And as you can see here, it is really for home readings, it is very, very high. Around 150, sometimes even higher. So really high readings. You did some 24-hour blood pressure readings, and it was confirmed. It was 158 over 96 millimeters mercury in the daytime average. So the diagnosis is proven. This guy really suffers from a severe hypertension. Now my task is, can we rule out primary hyperaldosteronism in this person, and how can we do that? There are some guidelines. They are not brand new, but they are still the actual guidelines from 2008, can be downloaded free in the internet from Professor Funder. The prevalence in general hypertension patients is very low, but if you go for resistant hypertension, then they go up higher than 10%, as you heard by Mark Safova. So if you have a patient that is either young or severe hypertension, then you really should look for primary hyperaldosteronism. The thing with primary hyperaldosteronism is that if you look at the textbook, you can see that in more than 70% it's unilateral adenoma, but that's because these were the cases with the hypokalemic form. So if you have a hypokalemic patient, and then it's more likely to suffer from unilateral disease. If you have a monokalemic patient, which is definitely has a much higher prevalence, then you have more often a bilateral disease, and that's the problem. You do not only have to find the con, you also have to look whether it's unilateral or whether it's a bilateral disease. Very, very few cases of familial hyperaldosteronism, but that's only 0.5 to maybe 1%. So how does it actually work with the aldosterone? So you have the tubule cell in the kidney. The aldosterone docks intracellularly at the mineralocorticoid receptor in the nucleus, and then the endothelial sodium transporter will be transcribed. Potassium will be shifted outwards, and you will have sodium and water retention. The renin goes down. This is a normal crosstalk, and that's how it works if it's controlled. If you have now an autonomic aldosterone production, you have lots of aldosterone docking to the mineralocorticoid receptor, and lots of on the tubular renal side, the sodium transporter. The potassium goes down and the renin is suppressed. So that's the case if you have an autonomic aldosterone production. So the therapy is either you somehow get rid of the aldosterone production by adrenalectomy, but only if it's unilateral. You cannot remove both adrenals. The second choice is, in particular, if you have a bilateral disease, you block the mineralocorticoid receptor by spironolactone or eplerenone. And the third is to block the endothelial sodium channel. The problem is in Germany we don't have the drug by itself. We only have it in a combined form, and that is not very helpful. So you can combine it with the spironolactone, but then you have to order the triamterene. We can order it from the international pharmacy, but it's not that easy. So practically, you have the first step. You have to screen, and not screen by potassium, because as I said, most cases are bilateral and they go with normal potassium. So the first screen, aldosterone to renin ratio. But then you have to be careful because lots of drugs we are using are interacting with the aldosterone, with the renin. So there are some of the drugs shown here, in particular the sympatholytic drugs, the beta blockers. Their mechanism of antihypertensive action is by suppressing the renin. So you can check whether your father-in-law is taking the beta blockers by just measuring the renin. If the renin is not going down, then he's not taking the beta blocker. And that brings you a false positive result. The diuretic increases the renin, or the ACE inhibitor, that increases the renin, and you get false negative results. The problem is that we heard already by Jürgen Ademacher, you cannot stop the medication, especially not in a patient with severe hypertension. So you have to interpret the results. In other words, if you have a patient on an ACE inhibitor plus a diuretic, and he still is positive in his aldosterone to renin ratio, so suppressed renin, then you can be sure, without changing the medication, that this patient must suffer from primary hyperaldosteronism. Otherwise, you have to change this or that tablet. These three shown here are okay. They do not interact with the aldosterone-renin ratios. The calcium channel blockers, the direct vasodilators, and the alpha-1 blockers. The spirolactone in particular, you have to stop that. Otherwise, you cannot measure the aldosterone-renin ratio. So the next step is a confirmatory test. We use the salt loading. So you infuse 2 liters of 0.9% sodium chloride over 4 hours, and you want to see whether the aldosterone is autonomic or can be regulated. If it drops, then it's regulated. If it does not drop, it's autonomic. And then comes the difficult part. You have to decide whether it's unilateral or bilateral. Mark Sapowal said you can do imaging and you can see, but I'm not that sure that imaging can tell you whether there's something on the other side as well. So if you have this distinct node, you saw in Mark Sapowal's pictures, then I agree, young person, one good node, 1 centimeter here, like you see it on the left side, unilateral disease. But if you are not sure, you have to do adrenal vein sampling. You have to do the CT anyway because you use it as a guiding CT, because the adrenal vein sampling is very difficult. You have to be at the adrenal vein and you have to sample the blood directly there and then compare one side with the other. It sounds easy, but unfortunately it isn't easy. We tested that for our university and others in Germany, and we saw that only 30% the radiologist or the interventionist was able to see or to cannulate selectively. So you basically cannot work with 31%. We increased that number over the years by doing rapid cortisol assays and being just more experienced with the procedure, so that at the end we increased it to 74%, and then we were able to really functionally see whether it's a uni or bilateral disease. So as a conclusion, if the renin is high and the aldosterone is high, then you have essential hypertension or you have a renovascular disease. Yeah? The renin is then increased in renovascular hypertension. If both is very low, you have Cushing disease, Little syndrome, or he just eats too much licorice. The primary hyperaldosteronism, you have this autonomic aldosterone production, and then the renin is suppressed. That gives you a hint that your patient might suffer from primary hyperaldosteronism. I told you that it's very common in patients with resistant hypertension, and in particular, if you have a suppressed renin, the beta blockers won't work, ACE inhibitors won't work. So your drugs that you give your patient just doesn't work. So you have a good bias that in resistant hypertension, drug-resistant patient might suffer from primary hyperaldosteronism. We should screen not every patient, but especially this young person, for example, and resistant hypertensive patient, and patient with low potassium. You have to interpret the results by knowing which drug is doing what to the renin, especially, as I said, the beta blockers increase the renin, the diuretics and the ACE inhibitors increases the renin. Spironolactone needs to be stopped Then the third step is confirmatory testing by salt infusion. And then the last step is crucial because you want to treat your patient right. You have to decide whether it's a unilateral or bilateral disease. And personally, I think only at the moment adrenal vein sampling will help you because it's a functional test and gives you really the site which is important. And then the treatment is, if it's a unilateral disease, you can do adrenalectomy, but be careful. This needs spironolactone treatment before the operation. And in the bilateral disease, you only can go mineralocorticoid blocker like spironolactone or epinephrine. Thank you for your attention.